A quality minute with Cole Beeler. Let's talk about how we can prevent surgical site infections with antibiotics. We're going to focus on colectomy and hysterectomy because these are reportable as a quality metric, but this discussion probably applies more generally to any surgery. Over the last decade, we've seen improvements in post-operative infections, and a lot of this is related to bundled evidence-based interventions, including antibiotics that prevent antimicrobial growth as tissue planes are invaded. Unfortunately, the pandemic led to major disruptions and tribulations in the surgical pipeline, which led to an increase in surgical site infections in some centers. In one center, a 40% increase in infection ratios during COVID was attributed to an increase in urgency of the cases being done, and in that setting, a significant worsening of antibiotic selection and administration timing. The authors concluded that development of cultural resiliency was needed to help compensate for the errors. Easier said than done, but what can we do to improve antibiotic administration in the operating room? Our colorectal experts aren't the only ones that may be manipulating the colon in the OR, and multiple surgical specialties might be submitting cases to the CDC and NSQIP related to post-op complications. When there's an anticipated breach of the colonic mucosa, the recommended antibiotics are seen above. I would note coverage for strep and staph to cover the incision, coverage of E. coli, Klebsiella proteus to cover gut gram facultative gram negatives, and coverage of anaerobes in these regimens. On retrospective review of surgical site infection cases, the most common errors we are seeing are omission of the anaerobic coverage with metronidazole and failure to redose when antibiotic concentrations are diminishing. You'll note that the recommendations for hysterectomy are very similar to colectomy, and I would draw attention that the errors are the same here as well. To add complexity and difficulty to an already challenging situation, dosing intervals will change depending on the creatinine clearance, which is also likely not at steady state in the OR setting. And what if your patient has a penicillin allergy? Well, I would start out by saying that most patients who say they have a penicillin allergy do not have a penicillin allergy. In the study on the left here, out of almost 800 patients that reported allergy, only 55 or 7% had a positive penicillin skin test. Most allergy wears off with time. And even if it doesn't, the cross-allergenicity with cefazolin is so low at less than 1%, empiric use is very acceptable without challenge. And it's worth delineating and being skeptical of these fake allergies because patients who have a listed penicillin allergy end up getting worse antibiotics in the OR, and that translates to an increased risk of surgical site infections by up to 50%. I wouldn't ask you to use chopsticks to remove a gallbladder. Why would we be okay with a Nissan when your patient deserves a Corvette? So, how do we improve this complex dosing situation to improve patient outcomes? First, have a clear plan for the antibiotic, its selection, course, and administration, well before the incision when possible. Be skeptical of your penicillin allergic patients. Ask them questions about this. Address it in PAT clinic, address it in pre-op. Be comfortable with cefazolin. Make sure the OR team knows what the plan is. No one person owns the antibiotic administration in the OR, but surgeons, nurses, anesthesiologists, pharmacists, infection preventionists all have a stake. Use your team to meet the guideline recommendations. Use non-human systems to remind you on redosing, and build the guidelines into your protocols. This should be a team effort. Thanks for listening.